Welcome to the Deep Dive. We're here to help make those tricky medical topics just a bit clearer for your MSRA prep.
And hopefully a bit more interesting, too.
Definitely. Today, we're diving into Horner's syndrome. It's a really, a really neat example of how our nervous system works and what happens when things go slightly wrong.
Exactly. And it shows up in quite visible ways, especially around the eye.
Yeah.
Super relevant for the MSRA.
So Horner's syndrome, it's basically a group of signs, right? Clues that something's interrupted the sympathetic nerve supply to the eye.
That's the core of it.
Yeah.
The sympathetic system, that's the automatic stuff. Pupil size, sweating, things we don't consciously control. An interruption there causes the problems.
And the classic signs everyone learns are Ptosis, the droopy eyelid.
Yep, a partial droop, usually. Not completely shut.
Right. Then Miosis, the smaller pupil, so the pupils are different sizes.
It's called Anhidrosis, yeah.
And Anhidrosis, less sweating on that side of the face.
That's the classic triad. But there's definitely more to unpack.
Okay, so our mission today is to give you that solid, high-yield rundown for the MSRA. Everything from the definition, causes, features, how to investigate it, the works.
And we'll throw in some memory aids, too. We're using a pretty comprehensive overview as our guide.
Perfect. So we've mentioned the signs. Let's get a bit more formal. What's the textbook definition?
Okay, formally, Horner's syndrome is a collection or constellation of signs and symptoms that happen because of a disruption somewhere along that sympathetic nerve pathway going to the eye and the face.
Got it. Can we just quickly run through those core features again? What do they actually look like?
Sure. So, Mitosis, you'll see the upper eyelid is lower than the other side. Looks a bit sleepy, maybe.
Okay.
Miosis, the pupil is smaller. You really notice the difference, the anisocoria, especially if you dim the lights.
Ah, right. More obvious in dim light.
Exactly. And anhidrosis, the skin on that side, often the forehead, feels drier because it's not sweating as much.
And you mention enophthalmos sometimes, the eye looking sunken.
Yeah, it can look like that. The eye seems a bit sunken back. Often it's more of an illusion because of the slightly droopy eyelid, but it's sometimes mentioned.
Good to know. Any other names for it, just in case they pop up?
Yeah. You might see Bernard Horner syndrome, or sometimes oculosympathetic paresis.
Oculosympathetic paresis. Okay.
They all mean the same thing, though.
Right. So we know what it is. Let's get into the why, the neuroanatomy. What's going on with the nerves?
This is where it gets really interesting, I think. It's all about that sympathetic pathway to the eye being interrupted. You can think of it like a three-stage relay race for the nerve signal.
A three-stage relay. Okay, I like that. Where does it start?
Stage one, the first runner or first-order neuron starts way up in the brain in the hypothalamus. Then it runs down through the brainstem and into the spinal cord, ending up around the C8 to T2 level, so upper chest area.
Okay, brain down to the upper spinal cord. Who takes the baton next?
The second runner, the second-order neuron, it leaves the spinal cord, typically at T1, joins this network called the sympathetic chain, which runs up alongside your spine in the chest and neck and carries the signal upwards.
Up the chain.
To a sort of relay station in the neck called the superior cervical ganglion. That's usually around the C3, C4 level.
Okay, so spinal cord, up the chain, hand over in the neck, final leg.
The final leg, the third-order neuron, it leaves that ganglion and kind of piggybacks along the internal carotid artery.
Ah, it travels with the artery.
Yeah, goes through the base of the skull, through an area called the cavernous sinus, through an opening into the eye socket, the superior orbital fissure, and finally delivers the message to the eye muscles.
Which muscles specifically?
The ones that pull the pupil open, dilate it.
Huh?
Also a muscle that helps lift the upper eyelid, Miller's muscle, and the sweat glands on the face.
Wow, quite a journey. So a problem anywhere on that route.
Exactly. Damage anywhere along that first, second, or third neuron path interrupts the signal, and you get Horner's. And where the interruption happens tells us a lot about potential causes.
Right, because different things can affect different parts of the path.
Precisely. A stroke might affect the first neuron in the brainstem, while a lung tumor might press on the second neuron in the chest.
Okay, let's talk about those causes then, the etiology. What kind of things generally cause this damage?
Broadly, you're looking at physical injury, maybe tumors pressing on the nerves, issues with blood vessels like dissections or certain neurological disorders, anything that can damage or compress that pathway.
Are there any quick clues? Like if you see Horner's, does anything else point towards a specific cause?
Sometimes. Like if a baby is born with a congenital Horner's, they often have different colored eyes. Heterochromia.
Oh, right. You mentioned that. Why does that happen?
Well, the sympathetic nerves actually play a role in the iris getting its pigment. If those nerves aren't working from birth, the iris on the affected side often stays blue or lighter, while the other one develops its normal color, usually brown.
Fascinating. Anything else?
There's some eye drops, like aproclonidine, that can help confirm the diagnosis pharmacologically. We can talk more about those later.
Okay, let's break down the causes by where the lesion is. Starting central, the first-order neuron problems in the brain or spinal cord. What are we thinking there?
So think big things affecting the CNS: strokes, multiple sclerosis, tumors near the pituitary or base of the skull, infections like meningitis, especially basal meningitis, maybe from syphilis. Neck trauma is a big one, dislocations or artery dissections like a carotid dissection.
Carotid dissection.
Okay. Also, things within the spinal cord itself, like syringomyelia, Arnold-Chiari malformation, or spinal cord tumors.
Quite a list. What about preganglionic, the second-order neuron? Problems in the chest or neck?
This is a really key area for the MSRA. The classic cause here is an apical lung tumor, a Pancoast tumor, right at the top of the lung where it can easily press on that sympathetic chain going up.
Pancoast tumor, definitely one to remember. What else?
Swollen lymph nodes, maybe from lymphoma, leukemia, TB trauma to the chest or neck, perhaps during surgery. In kids, you have to think about neuroblastoma.
Right, neuroblastoma in children.
And even, surprisingly, sometimes a really bad dental abscess in the lower jaw can track upwards and affect these nerves.
Wow, a dental abscess. Okay. And the last part, postganglionic, the third-order neuron, closer to the eye.
Here, causes can include things like cluster headaches, that's a strong association, or migraines, shingles, herpes zoster, affecting the face. There's something called Rader's syndrome, problems in the cavernous sinus, like a carotid cavernous fistula, or even temporal arteritis, inflammation of the artery.
Okay, that's a lot of potential causes. Is there a simpler way to maybe group these mentally?
Yeah, I think it helps to think. Central, brain spinal cord. Preganglionic, chest neck, near the sympathetic chain. Postganglionic, head near the eye after that last relay station.
Central, preganglionic, postganglionic, brain, chest, neck, head, eye. That helps.
So risk factors, are there specific things that make you get Horner's?
And not really risk factors for Horner's itself. It's more that the risk factors are for the underlying cause. So if you have risk factors for stroke or lung cancer or neck trauma, then you're indirectly at higher risk of developing Horner's because of those conditions. It's a consequence, not usually a primary condition with its own risk factors.
That makes sense. It's a sign of something else. Let's quickly touch on the pathophysiology again, just to be clear.
Sure. It's simply that interruption anywhere along that three-neuron path means the final sympathetic signals don't reach their targets.
So no signal to the muscle that lifts the eyelid slightly.
Gives you Ptosis.
No signal to the muscle that dilates the pupil.
Gives you Miosis.
No signal to the sweat gland.
Gives you Anhidrosis. It's a direct result of that lost connection. Right. Okay. Now, because some signs overlap, like picosis, what are the main things we need to differentiate Horner's from? The differential diagnosis.
Yeah, crucial point. For ptosis, the big one is a third nerve palsy, but that usually causes a complete ptosis, the eyelid's totally shut, often with a dilated pupil and eye movement problems. Very different picture.
Okay, third nerve palsy looks different. What about the small pupil, Miosis?
Well, certain eye drops can cause miosis, like pilocarpine used for glaucoma, so always check medications. And there are other neurological reasons for unequal pupils, different kinds of anisocoria.
And the Anhidrosis.
Other things can cause patches of reduced sweating too. So you really need to look at the combination of signs, the ptosis, Miosis, and Anhidrosis together on one side that points strongly towards Horner's.
It's the pattern. Got it. How common is this? Epidemiology.
It's considered pretty uncommon. UK figures aren't precise, but the general estimate is maybe 1 in 6,000 people, and doesn't really favor any particular age, sex, or race. It can happen to anyone if the cause is there.
1 in 6,000. Okay. Let's really solidify the clinical features. We have the triad, but what else might we see, or what might the patient report?
Okay, so the core. Unilateral partial ptosis, Miosis more obvious in the dark, remember, and ipsilateral facial anhidrosis.
Right.
You might also see the apparent enophthalmos. Patients might feel the eyelid is weak, or notice the lower lid is slightly higher up than usual on that side. Sometimes they can't open the eye quite as wide. If it's a preganglionic lesion, you might actually see some facial flushing on that side initially. If it's postganglionic, think about pain, orbital pain, or headache, like with cluster headaches.
Okay, pain with postganglionic is a clue.
Yeah. And always ask about related symptoms: neck pain, arm pain. That could point to a dissection or a Pancoast tumor. Oh, and a subtle one is increased accommodation, They might focus better up close in that eye.
Interesting.
And don't forget heterochromia if it's congenital.
Yeah.
And always feel for lymph nodes in the neck or check for other signs related to potential causes.
That's really thorough. And you had a mnemonic for the main three.
Yep. Ptosis, Miosis, Anhidrosis. Think PMA, like positive mental attitude. But here, PMA is not good. It means lack of sympathetic drive.
Chemo is not good. I'll remember that.
Oh.
Okay, so we suspect Horner's. How do we investigate?
Two main goals. Confirm it is Horner's and find the cause. First, a good clinical exam. Look closely at the pupils in bright and dim light. Check for ptosis, check for sweating differences.
Then imaging.
Often, yes, depending on the suspected cause. Chest x-ray is common, looking for that Pancoast tumor. CT or MRI of the head, neck, and sometimes chest, looking for strokes, tumors, dissections, you name it.
Mm-hmm.
If you're really suspecting a carotid artery dissection, then a CT angiogram or maybe a carotid Doppler ultrasound would be specific for that.
Right, and those eye drop tests, the pharmacological tests.
Yes, they're quite neat. They help confirm and localize. First, cocaine drops. Normally, cocaine stops norepinephrine reuptake, making the pupil dilate. In Horner's, there's less norepinephrine being released anyway, so cocaine doesn't dilate the pupil much, or at all. That helps confirm it.
So cocaine confirms by failing to dilate.
Exactly. Then there's aproclonidine. It's a weak sympathomimetic. Normally, it doesn't do much. But in Horner's, the iris muscle becomes super sensitive due to the lack of normal signals. So aproclonidine will cause the Horner's pupil to dilate. It sort of reverses the anisocoria temporarily.
Okay, so aproclonidine does dilate the Horner's pupil, also helps confirm.
Yes, and then to help figure out if the problem is before or after that last relay station, the superior cervical ganglion, you can use hydroxyamphetamine drops. This drug works by forcing the nerve ending to release its stored norepinephrine.
Okay.
So if the third-order neuron is intact, meaning the lesion is preganglionic first or second order, hydroxyamphetamine will make it release norepinephrine and the pupil will dilate. But if the third-order neuron itself is damaged, a postganglionic lesion, it has no norepinephrine to release, so the pupil won't dilate with hydroxyamphetamine.
So dilation with hydroxyamphetamine means preganglionic lesion. No dilation means postganglionic. Clever.
It is pretty clever. It helps narrow down where to look for the cause.
Is there an easy way to remember those drops?
How about thinking cocaine confirms? Aproclonidine also confirms and reverses, and hydroxyamphetamine helps find the home of the lesion, CAH.
CAH. Got it. Okay, we've diagnosed, maybe located the lesion type. How do we manage Horner's?
Management is all about treating the underlying cause, whatever that might be.
So not treating Horner's itself, but the reason for it.
Precisely. If it's a tumor, treat the tumor. If it's a dissection, manage the dissection. If it's caused by trauma, manage the trauma. The treatment is tailored to the primary problem.
Makes sense. And follow-up is important.
Definitely. Regular follow-up with specialists, like ophthalmologists or neurologists, is key to monitor the situation and manage the underlying condition.
What about the prognosis? Does Horner's go away?
It really depends entirely on the cause. If the underlying issue resolves or is treated successfully, sometimes the Horner's signs can improve or disappear completely. But if there's permanent nerve damage, then the mitosis, Miosis, and maybe Anhidrosis might be permanent too. Highly variable.
And complications. Are there dangers from Horner's itself?
Again, not really from the Horner's signs themselves. The complications are linked to the underlying cause. A tumor can obviously have serious complications. A carotid dissection can lead to stroke. So the focus is always on the primary pathology.
Okay, so let's try and sum that up. Horner's, ptosis, Miosis, and hydrosis, caused by interruption of the 3-neuron sympathetic path to the eye.
Right. From hypothalamus down the spinal cord, up the sympathetic chain, along the carotid to the eye.
Causes depend on where the lesion is central. Preganglionic, think Pancoast, or postganglionic, think cluster headache.
Clinical features plus pharmacological tests help confirm and localize.
And management targets the cause, with prognosis depending entirely on that cause.
You've got it. Shall we try a quick MSRA-style question?
Let's do it.
Okay. A 45-year-old man, heavy smoker, presents with a new droopy left eyelid and a smaller left pupil. What's the most likely underlying cause?
Based on what we said, heavy smoker, signs of Horner's, gotta be thinking Pancoast tumor, apical lung tumor.
Spot on. That's a classic association they like to test.
Okay, my turn. Which eye drop test helps distinguish a postganglionic lesion?
That would be the hydroxyamphetamine drops. No dilation points to a postganglionic problem.
Perfect. It really shows how these specific signs can point you towards some pretty serious underlying conditions.
Absolutely. It's a reminder to always think about the why behind the signs. What else presents with subtle signs but has big implications? Worth pondering.
Definitely food for thought. Well, that was a great deep dive into Horner syndrome, hopefully really useful for everyone prepping for the MSRA.
And if you want more in-depth revision materials, check out pastthemsra.com.
And for loads of free practice questions and other learning tools, head over to freemsra.com. Thanks for joining us on the deep dive.